And today we have on set Dr. Meriel Norris, who is a physiotherapist, researcher, as well as an educator with a truly global perspective. She's worked across the United Kingdom, India, and Indonesia, specializing in neuro-rehabilitation and experiencing how people go through recovery and care after stroke. At Brunel University, London, Dr. Norris leads several postgraduate programs in advanced clinical and professional practice, combining hands-on expertise and research-driven techniques. Her work bridges health, anthropology, and education, all with a focus on equality, diversity, and inclusion in healthcare. Hello and welcome to EduCon's podcast series, where we speak to global higher education institutions to understand what's happening in the world of education. My name is Jannavi, and this conversation is brought to you by Java and Skoda. Dr. Norris, thank you for joining with us today. I'm very excited to chat more with you and learn what you've been doing here at Brunel. So, since you are the professor of rehabilitation, I believe that rehab as a word has evolved so much over time. I think it's more than just physical. Perhaps there's some involvement of, say, mental well-being that's also in it. How would you define rehabilitation now?
It's a really good question, and you're not wrong. It has changed a lot from very much kind of trying to originally thinking about getting people back to their kind of physical normality to actually now more thinking about how people transform after a long-term illness or disability or something like that. And that, of course, has to encompass everything. Mm-hmm. So I'm a physiotherapist by background. So while some of my aspects will be about their physical well-being, that has to relate to function, that has to relate to their everyday life in the community that they're in. But of course, that's only one aspect of it. It has to also involve their participation in life, in work, in their community, and that will also relate to their psychological or mental well-being with it. And a lot of the concepts here now are moving not just about thinking about how do we help people to reevaluate and rediscover actually what they can be after a long illness or a disability, but also how they can continue to live with their condition. And so there's very much this concept of the lifespan of actually it's not just about 6 weeks after an injury or 6 weeks after a stroke or something like that. It's how do they go on to live well in all of those different aspects, which involve every aspect of their physical, mental, social, psychological, and general well-being, quality of life.
Wonderful. And just to talk about some of the research that you've been working on, can we hear more about that as well?
Yeah, I mean, there's a whole mixture of stuff. Actually, I've placed myself into a number of positions. All of it is generally in the area of neurological rehabilitation, but we work in a number of different areas. So within people who've had a stroke, but also people with multiple sclerosis and people with Parkinson's disease. Mm-hmm. We've done research that's looked at trying to improve certain aspects of their rehabilitation, whether that be their physical activity, their functional capabilities, usually within the community, but also we've done some work trialling new technology within stroke rehabilitation, specifically supporting the recovery of the upper arm, both within hospital in the acute situation and at home. And then my work in cerebral palsy, which is quite a different area. The focus has for decades been in young people within research, kind of below 16 years of age, and real focus on that. And actually with the way that lifespans have gone and people's health have gone, people with cerebral palsy are living very, very long lives. And there's very little research looking at what happens when they transition to adulthood, what happens when they have children, what happens within their workplace, what happens when they get older. And there's been a whole suite of work that we have been doing, looking at risk factors for other conditions, but also this aspect of how they live well with their disability through self-management, through being able to navigate the systems, through being able to balance their work and their life through the rest of their life course. So this life course approach to rehabilitation has been quite a new focus. And while there might be specific periods of time that you really want to target acute rehabilitation or the transition periods, actually we do need to think of rehabilitation in the longer term as people grow older with disabilities. And that's what a lot of our work has done. And a new project that I'm just getting involved with now is looking similarly with stroke. There was some previous work we did with that, but now an international collaboration looking at how to live well with stroke.
That's fascinating. I would actually love to ask you more questions around that. So when we look at this aging population that essentially you're also trying to help, right, through your research, what are some of the biggest challenges and perhaps, obstacles that you're seeing when it comes to such research as well? Is there anything that we can also hear about you?
The obstacles to doing the research?
Yes, or in terms of, say, if there's any findings that you've had which have been particularly very interesting to learn about.
The findings are, all of them are interesting. I'm a researcher, so everything's going to be interesting. I think some of the biggest findings that are interesting but equally upsetting, actually, is the fact that the focus on mental health has been totally understudied, and the high rates of mental health issues, but also the fact that having a disability earlier on in age puts you at much higher risk of other conditions later, many of which are modifiable, many of which are preventable if they're given the right support to do so. But the support that's currently in place is very targeted at the more standard population, and so they're excluded from those messages and excluded from that ability to actually improve their own lives and take control of their own lives because the messaging and support is not there. So I think that's what we're working on quite a lot at the moment, is actually strategies for people to kind of arm themselves with the information. What information do they need, and then how they can navigate and work with the resources that are available in order to promote their access mental health services if they exist. I'll come to that in a minute, but also where there are services that perhaps be more targeted for more mainstream population. How can we work with the providers to be able to manage and focus on some of the specialist needs, but at the same time how we can arm the people who are living with this condition, who are the absolute experts on their condition? How can we support them to actually direct their own travel? And that's the research we're doing at the moment, particularly in cerebral palsy, is actually looking at development of training packages, having done all the understanding of what the issues are, both for them personally, their families, but also service providers. Can we create packages of support structures that are sustainable and that allow them to both have services but also know how to access and know how to navigate the systems which are complicated? That's in our systems here and in Ireland. They're really quite difficult to navigate. In terms of the barriers to research, this is a long list. I think one barrier is our imagination. I think we've been so focused on rehabilitation being immediately after an accident or after a kind of period of time that the longer term rehabilitation needs have been no, that's not true, not entirely, but they have been neglected from research. And that's clear in some areas more than others. So longer term conditions, for example, like multiple sclerosis, there may be more awareness of that, whereas with stroke, that's had a massive increase in research, that's been very focused on the acute period, and actually what happens in the long term has been relatively less funded and relatively less focused on by researchers. And in areas like cerebral palsy, looking at people with adult cerebral palsy being basically ignored. I mean, the research in the last 5 years is really, that's where it's coming. And the group that I work with is very kind of fundamental to developing that area. So I think part of it is about imagination of actually looking at what's happening with population changes and what that means for rehabilitation, and putting your focus maybe not on what has always been your focus, but on what is needed now. But the other thing is this is not singular. I'm a physiotherapist. I'm also an anthropologist by training, and all of these things are interprofessional, intersectorial. You know, if you're thinking about rehabilitation in the concept that I talked about before, you have to work with transport systems, you have to work with education systems, you have to work with the food systems of the country, you have to work with the public health community, you have to work with vocational and training aspects. It's life. It's everybody's life. And if we just stick with just physiotherapy or just education, then we're missing the ways in which these sectors have to communicate, and therefore research also has to have the imagination to work across these different aspects and have these kind of interprofessional and intersectorial kind of components. That leads to another challenge, which is how do you create that and who funds it? And that is a perennial problem. You know, rehabilitation isn't as well funded as more acute medicine, history.
Okay.
But also there is perhaps, research in rehabilitation is evolving. It's not new, but it's still relatively, it's still growing as a concept. And I think the capacity to facilitate this complex intersectorial stuff is something that really the funders are getting better at, but they need to invest more time, more money to support that kind of development work if we are really going to make a shift in the long term to the quality of people's lives in their long term, in their long lives.
Wow, fascinating. And if we talk about, for instance, the kind of research collaborations that can potentially happen, say even cross-border or internationally, right, perhaps with India or any other nation, what are your thoughts on that? How do you perceive that?
Well, I may or may not be a typical researcher in this. I wasn't born in the UK. I did my PhD overseas. I've worked overseas quite a lot. So for me, kind of internationalism is a strength. You know, that we understand things about different, and I live in London and I work in London, which is a totally international city. So for me, international collaborations are absolutely essential to share knowledge as a starting point, because different expertise will develop in different areas. But also it's really important that the research that is invested, you know, the money that's invested in research, that research has potential to cross over different places, because the needs that we have internationally are immense. And so if I take, for example, something like stroke, which I clinically worked in for many years, and I studied in my PhD, but in Indonesia, not in the UK, we know that actually it is a huge concern within kind of high income countries, but it is an even bigger concern in the middle income, lower income countries, where the transfer from communicable to non-communicable diseases is still happening. And actually, if we're doing research that just sits in our communities, then we're missing a trick. There is potential for us to share that, but only if we have those collaborations and we have those conversations. But also, from my experience of working, I've spent a number of years working in India, in Indonesia, and other places. Actually, the innovation that comes from those countries is really exciting. And there is a lot to learn from actually those conversations, whether it be how to simplify some of the systems that we create, which are fine when you've got hundreds of qualified and specialist therapists in your team. But if you don't, how can you adapt to that? And actually, these are questions that are relevant to us in the UK, but actually other countries might be asking those questions in quite a different way. And therefore that collaboration benefits everyone. So for me, it's kind of, why would you not do it rather than why would you do it? The practicalities of doing it, though, are, of course, complex. Funding aside, you have to really understand that systems are different, priorities are different often, but if there is a shared end goal and if there is mutual respect, and therefore for me, collaborations are absolutely about partnership with equal understanding of expertise and balance. And also you need to involve all sectors that are involved in that. So I have collaborations at the moment which work with big national organisations, but also work with really small local non-government organisations who are trying to deliver rehabilitation to people in the most rural communities where there are no therapists. And therefore, how are they trying to resolve that? So I'm, one, working on VR and robotic technology, which I don't spend a lot of time doing, but there is some work in there, right to the other level of working in the community with people who've had spinal cord injuries or stroke, and actually how these organisations are problem solving to try and get the best rehabilitation in its broadest sense in those conditions, supporting them with their research capacity to ask the right questions to study so we can get some meaningful data from that, but also to then think about what the lessons that we can all learn from our side to theirs, from their side to ours. And that's kind of how I think about my international collaborations today. And that's how I hope I continue to think about them, because for me, that's the way to move forward, actually, to make it worthwhile and to make a change on both sides.
I love the sound of that. Sounds very, very interesting. For any person who's watching this and wants to pursue a career in rehabilitation as well, and is, maybe they're trying to figure out what the future trends are, what makes sense, what doesn't make sense. Any word of advice to our viewers?
Loads. I mean, I think the trends are really difficult because, of course, the trends in context will be different. So, for example, in the UK now, we have a trend through a government change, which is trying to shift rehabilitation out of institutions into the community. And so we have to be quite creative, both in our research and our education, about understanding the best mechanisms for that. And how to deliver that in the best safe ways, etc. That will be slightly different to what happens elsewhere. But this shift in terms of looking at long-term conditions, looking at chronic conditions, and how to age more healthily, both for people who have conditions and those that don't have conditions, is for sure not going away. And we have not really addressed that appropriately. And as I've said, that's a public health, that's an education, that's a rehab that covers all sorts of different things. So I think that is definitely something we need to think about, the ageing population. How can we support people to live well? And that doesn't mean not necessarily live without disability, but live well with a disability or live well with a condition, that we can't eradicate every condition, but how can we support people to live well with that? I think that will be a big story and massively important in relation to mental health with that. So as I said, but I think the how, if I was going to give a message, I'm a therapist, and I strongly believe that the allied health professions in their multiplicity have a huge amount to offer here, both as researchers, because rehabilitation professionals think of the whole person. That's what we do as our job. We don't look at a leg or an elbow or a knee or just your mental health. We look at the whole person. Well, we should. And I think that gives us great scope to, one, really know what the kind of issues are for the people who are living with these conditions and work collaboratively with them to understand what their needs are, but also to lead on research. And that means we have to be empowered to understand research, understand the complexity of research in this field. And that means we need to educate ourselves. We need to educate ourselves in research, in leadership, in order to take the problems that we understand work with people effectively, and then be able to support the research that really will have impact. And if allied health professionals can continue to do that, it's happening, we do more of that, then I think we will see a change. So that would be my biggest message, is any therapists, nurses who work in rehabilitation, public health people in education who have an interest in rehabilitation, is learn more about research. You know where the gaps are. You're working with the people who can identify the gaps, and then arm yourself, collaborate with people who are doing research, and then make the change, but make the change from the ground up. That's where I really would like to see it happening, from the people who know and understand where the issues are, to make the change.
Yeah, that makes so much sense. Dr. Norris, thank you so much for your time. It's been fantastic chatting with you and listening to you and all the insights that you had. Thank you very much.
Pleasure.